2 months ago, one of our speakers for today, State Senator Bob Shoemaker, wrote the club's program committee to express his interest in participating in a City Club presentation on the Oregon Health Plan. At that time, he said it's a bit early to tell exactly what legislation will emerge, but he added, it's not too early to predict that there will be significant legislative action here and in Washington, D.C. Today, 2 months later, both the progress report and the prediction appear to remain accurate. The pending legislation in Salem is obviously a major issue to be resolved before the current session of the legislature is to end. The senator in his letter was also on target when he said that the business of implementing a statewide health plan is a complex subject, but one that is important for Oregonians to understand. We're fortunate today to have with us not only the senator, but also Roger Auerbach, Governor Roberts' advisor on health, labor, and housing, to help us understand what is proposed for putting the Oregon Health Plan into action. State Senator Bob Shoemaker, as many of you know, is a member of the City Club and a former president of this organization. Elected to the Senate in 1988, Senator Shoemaker has chaired the Senate Committee on Health Care and Bioethics since 1989. He also serves on the Judiciary Committee and the Agricultural and Natural Resources Committees of the Senate. Bob Shoemaker has been an active leader in this community for 20 years. In addition to his service to the City Club, he has acted as chair of the Multnomah County Planning Commission, board president of the Oregon School of Crafts, Arts and Crafts, president of Schools for the City, and president of the Oregon chapter of the Nature Conservancy. A Portland native, Senator Shoemaker is a graduate of Lewis and Clark College and the Harvard Law School. Roger Auerbach is a top advisor to Governor Roberts. His policy responsibilities cover health, housing, labor, mental health, workers' compensation, occupational safety and health, insurance, and disabled issues. Before taking on his role with the governor, Roger was deputy director of the Oregon Council of the American Federation of State, County, and Municipal Employees, AFSCME. He's also served as president and chief executive officer of the Oregon Federation of Teachers. Roger serves on the board of advisors of the Working Assets Money Fund and the board of the Jewish Federation of Portland. He has served as chair of the Northwest Oregon Health Systems. Roger is a graduate of Alfred University in New York State and of the Boston University School of Law. It is a pleasure to welcome both of you to the Portland City Club. We'll begin with presentations of the remarks, first from Roger Auerbach. Roger?
Thank you very much. It's a pleasure to be with you today. Senator Shoemaker and I have divided today's presentation. I will present a short description and history of the Oregon Health Plan, and we'll discuss current issues before the legislature and short-term goals for the next 2 years. Senator Shoemaker will concentrate his remarks on programs he is working on for universal access to health care and for a managed competition system for the state of Oregon. Mr. President-elect, members and guests and friends, in healthcare discussions happening across the country, the state of Oregon is synonymous with rationing health care for the poor. Most of us don't like the term rationing, but what I say in response is that our state has made conscious policy choices in providing health care for our residents. We have decided that all medical services are not of equal value, and the services we want to provide are those that are medically effective and cost-effective. We have decided that it is better to give most medical services to all those who have incomes under the federal poverty level rather than to give every service to those who fit the narrow federal eligibility standards. We have decided that access to preventive services saves money and improves people's lives, and it is better than receiving care in hospital emergency rooms. And we have decided that we can save money and give quality care by encouraging service delivery through managed care organizations. But the state of Oregon should be known for much more in the healthcare field. Oregon was the second state in the country to enact a comprehensive health plan to guarantee all its residents access to quality, affordable health care. And we did it in 1989 with our pioneering Medicaid expansion to cover an additional 120,000 poor Oregonians, our high-risk pool to cover people who were denied health benefits, an estimated 20,000 people, and our employer-based health insurance program estimated to cover 280,000 uninsured working people. Most of you know the history of our attempts to get the federal government to give us the needed waivers to implement our Medicaid expansion. We were initially rejected by the Bush administration in August 1992 due to perceived discrimination against people with disabilities, and were finally granted the waiver by the Clinton administration a few months ago. But most of you probably don't know the history of our employer-based program, which will cover 280,000 uninsured compared to the 120,000 in the Medicaid expansion, the program that has gotten the bulk of the publicity so far. The employer-based program, as enacted by the 1989 legislature, required employers to provide health insurance to their employees and dependents by January 1st, 1994, unless 150,000 new employees were voluntarily enrolled by October 1st, 1993. If the voluntary target was reached, the employer requirement was to be repealed. Even though the state had enacted an inexpensive voluntary program in 1987 and expanded opportunities with a new program this year, it is acknowledged by all that this voluntary goal will not be met. The original date for the employer program was moved back by the 1991 legislature from January 1st, 1994 to July 1st, 1995. The reason for this move was the original 1989 plan anticipated that the employer program was to begin after the expanded Medicaid program, and in 1991, we had not been granted our Medicaid waiver, so the whole plan was delayed. The Oregon Health Plan was always envisioned as a public-private partnership where the state would cover all those people below the federal poverty level, and the private sector would cover all those working over an average of 17.5 hours per week. In fact, in 1981, the legislature amended the plan and mandated that the employer program would not go into effect unless the Medicaid program received the necessary waivers and was funded by the Oregon legislature. With the requisite federal waivers obtained, the public part of the plan is ready to be funded by the legislature, and planning for the implementation of the private employer program should begin in earnest. But something has happened on the road to health care coverage for all Oregonians. The private sector business community is now advocating that the employer part of the Oregon Health Plan be pushed back 4 years, from 1995 to 1999. Governor Roberts is opposed to a delay in providing health coverage for 280,000 working Oregonians. In 1989, the legislature told these workers that they would receive health insurance in January of 1994. The 1991 legislature moved that date to July of 1995. How much longer can we ask people to go without insured access to basic health care? And how much longer do all of us have to pay higher medical costs because the costs of the uninsured get passed on to the rest of us? Hospital representatives admit that they add up to 25% to each hospital bill to cover their uncollected billings. We need to restrain the escalation in healthcare costs, and the most effective way to accomplish cost containment is for everyone to have access to preventive healthcare services. The Private Sector Business Alliance also objects to any new revenues being used to pay for the public part of the plan. So after cutting over $1 billion from the state budget, the Private Sector Business Alliance wants to use lottery money and general fund money to pay for the plan. They want us to cut additional money from education, human resources from needed economic and community development projects. The governor has proposed a combination of tobacco tax and 0.5% tax on hospitals, doctors, and dentists to pay for the plan. Although she firmly believes that the plan should eventually be funded with general fund money, and has proposed that the provider tax be repealed upon passage of any tax reform measure, she has proposed this funding plan because she cares about the long-term health of Oregonians. Her plan would fund the Oregon Health Plan for at least the next 5 years. She rejects making additional budget cuts to fund the plan and believes that lottery money is not a stable funding source for delivering health care services for Oregonians. She wants the legislature to think long-term about financing rather than looking only to the next 2 years for funding. Even though there are major disagreements on financing the plan and the date for implementation of the private employer program, I continue to believe that compromise will be made so the Oregon Health Plan can finally begin. The governor has displayed great flexibility on these issues, and we hope that the Republicans in the House of Representatives care enough about health care for all that these outstanding issues will be resolved. But we still have much more work that needs to be done to present the 1995 legislature with additional policy choices to further refine the private portion of the Oregon Health Plan. Senator Shoemaker will elaborate on a number of these issues, but my list may be a little different than his, so let me elaborate on my short-term goals. First and most crucial, we must explore all avenues to control health care costs by both market incentives and by regulation. We simply cannot afford to pay for the status quo. We must explore ways to eliminate much of the burdensome paperwork inherent in the system and streamline administration in both the public and private sectors. We must explore more efficient health insurance purchasing and delivery systems without sacrificing the quality care we want and deserve. And we must not lose sight of the fact that we want to reform the health care system to make people healthier, not just to care for them when they are sick. Thank you.
Pleasure to follow you, Roger, and I must say that I really do enjoy working with you as we try to advance the cause of the Oregon Health Plan. President-elect Barney and fellow members, it's very good to be back among friends and family. I have family here as well. And I look forward to telling you where I think we're going. Roger laid out very well some of the problems we face. The employer mandate has been a sticky piece of this Oregon Health Plan really since it began. In 1989, the plan was passed by the legislature through the efforts of a strong coalition which included Associated Oregon Industries, which represents, by and large, the larger employers who do provide health care for their employees and don't like picking up the tab for those who don't. It was resisted by the National Federation of Independent Businesses, which by and large represents the smaller employers, many of which do not provide health insurance. But the NFIB did not prevail, and by a very narrow margin in the House, a substantial margin in the Senate, the Oregon Plan was adopted in 1989. Well, since that time, a lot of things have happened, as you've heard. And along the way, AOI has pretty much gotten off the wagon. They'll deny it, but I think the fact is that they no longer favor the employer mandate. That creates a very difficult political problem. Even if we save it this session, and I think we will, it's still at dire risk in the next session. Without the employer mandate, the Oregon Health Plan really isn't an Oregon Health Plan. It's an Oregon Medicaid plan. It will do a lot of good for 120,000 people, and we can be proud of it. But it is not an Oregon Health Plan, and it does not provide universal access to health care to all of us. And that is our goal, and we have to stay with it. In the special committee which was created a week ago to work on the bill which came over from the House, which would extend the employer mandate till 1999 and fund the Oregon Health Plan, the Medicaid portion, over the next 2 years, included an option to the employer mandate, which is an employee option, voluntary health insurance. That is what is proposed by the House as the viable alternative to an employer mandate. They would have us believe that everyone will choose to provide their own health care, even if they're not told that they have to do it. I think experience has shown us that that will not occur. Fortunately, there is a viable alternative to the employer mandate. It's an alternative that we're calling the individual mandate. The idea is not brand new. Uwe Reinhardt has proposed something essentially like this. The Oregon version has been developed over the past month by Senator Gordon Smith, a freshman Republican senator from Pendleton, and for the most part by me. And the more I think about it, the more I think it may well be better than the employer mandate. And during the interim, we will study the two of them very thoroughly, fill in the pieces, the missing pieces of the employer mandate, and there are many, and recommend to the 95 session, I believe, two alternatives. I mean, that an alternative to the employer mandate, two options, a choice. I'd like to spend the bulk of my time today describing the individual mandate and then describing how it would work within a healthcare delivery system and what that healthcare delivery system we expect to look like. So you can kind of have a picture of where I think we're going. As I say, it is still too soon to tell, but this is where I think we're going. First, we would require that all Oregonians belong to a health plan. Not an option, it's a requirement. Payment for that would be from income tax revenues or by employers for those employers who choose to continue to provide health care for their employees. The income tax would be collected for the most part via payroll deductions. Employers would be encouraged but not required to convert their health plans to direct compensation. The Employees Retirement Income Security Act, we understand, forbids us from requiring this. So even if we were inclined to do that, we probably can't. But we would encourage employers to convert their plans to direct compensation, thus providing the wherewithal for covered employees to pay the tax which would provide their health plan. We would fashion a new line item on the state income tax return, which we'd call the health plan income tax, separate it from the general income tax, partly so that we will all know what health care is costing us, and it won't just be lost in the general tax revenues. Each one of us would then be taxed probably a consistent percentage of our adjusted gross income with a ceiling so that there'd be a maximum amount that anyone would pay into the fund for this individually mandated health plan. The tax would be calculated to provide enough revenue to fund for each Oregonian who takes a plan that way as contrasted with from their employer, would be sufficient to fund the least expensive plan available, that certified plan available to that employee. Because of the way income tax works, the effect of this would be that those among us who could not afford to pay what it takes to provide health insurance, although they would still be paying a percentage of their adjusted gross income, would be in effect subsidized by those of us who can afford it. So now we've provided the vehicle for providing all of us with health insurance in a way that is fair. Those whose plans continue to be provided by their employer, and there will be a good number of those, would be entitled to take a credit against this tax equal to what the state-provided plan would cost if they were to take it that way. So in effect, they won't be paying taxes for something they don't receive. But they still would pay some tax. They'd pay the difference between what the plan would cost for them and what they would be contributing to the commonweal. And the beauty of this, or one of the beauties of this, is that this is all deductible from the federal return because it's an income tax. So in effect, the feds would be helping us do all this. We're not sure how delighted they'll be, but we think it's a pretty good idea. So that's the basics of how we provide for this individually mandated health insurance plan and see to it that certainly the bulk of us, probably a few will slip through the cracks, will pay our fair share to see to it that we all have health insurance. Let's move on. How would it work? If everybody is on their own to find and buy their own health care, you've really got chaos in the market. You'd have all kinds of peculiar-looking plans popping up with all kinds of attractions, some of which were genuine and some of which are false. You'd have cherry-picking in the extreme, plans calculated to attract low-risk individuals, leaving the high-risk to find their way into very expensive plans. That is not an acceptable way to provide health care. But a way has been developed, which we often link with managed competition, that pools all of us together for a lot of good reasons. These are called health purchasing cooperatives, or in this state would be health purchasing corporations. Perhaps 6 in the state, 1 for the metropolitan area of Portland, and 5 others for different regional parts of the state. Every one of us who isn't covered by an employer would be a member of the HIPIC for our region. And so that is the vehicle through which we would get our health care. These organizations, as I see it, as I say all of this, none of this is agreed upon yet, but this is the concept. These would be nonprofit corporations. The governing of those corporations would be by business and labor selected individuals. So this is not government. These are semi-private sector organizations, and they would be responsive to business and labor. Everyone in the region would be a member of the plan, and the plan's obligation, or one of its obligations, would be to make available to its members all of the different health care plans certified by the Department of Insurance and Finance for quality and financial stability, that all available health care plans would be described and offered to the members. They would each would select the plan that fitted that person or that person's family the best. If you pick the least expensive plan, it's paid for by taxes, which you have contributed to. If you pick a more expensive plan, which is you're free to do that, you pay the difference. You pay it from after-tax income. So there's no tax benefit of picking a more expensive plan, and we would hope the effect of this over time would be to have people accept and be satisfied with the basic plan, but it's their choice. The HIPICs, of course, would be funded by these tax revenues calculated to be sufficient to fund the least expensive plan for all of the members. Another great virtue of doing it this way is portability. One of the problems with an employer-based system is that you're stuck with the plan of your employer, and you're stuck with your employer. There are a lot of people who'd love to change jobs, but they don't dare do it because they're going to lose their health insurance if they do. Either they've become a high risk and they can't get it, or they really don't want to change doctors and the whole system that they've become used to. And the next employer has a wholly different system. We avoid all of that through this system because you're in the HIPIC, you pick your plan and you stay with it, and your employer is no longer relevant to the equation. So I think that's a really important virtue of this. Another is that the HIPIC, because it is large and represents a great number of people, has got real clout in negotiating with the healthcare providers, so that it should be effective to bring the premiums down. So what are they negotiating for? What kind of health care plans are we going to see out there in the marketplace? What we're going to see will be managed care plans, similar to, but not always identical to, HMOs, health maintenance organizations, such as is represented by Kaiser. Portland, particularly, is already well down the road in developing these managed care plans. The state would require that each managed care organization offer the Oregon Standard Plan. And that Oregon Standard Plan probably will be required to be substantially similar to the plan we've developed for Medicaid under the Oregon plan, the prioritized list, the rationed list. That would become the Oregon standard, probably. And each, excuse me, each managed care organization would be required to offer that plan. They can offer additional benefits if they choose, but they'd have to price those separate from the basic plan. So when you're selecting your plan, you're comparing apples to apples, because the basic plan for each is the same. And so then you can pick the plan based on quality and cost. And the premiums for these plans would be community rated as opposed to experience rated, a very important thing that we do. Experience rating means that it's like any other insurance. The price you pay reflects the risk that you present to the insurance company. Now that's fine for automobile insurance, homeowners insurance, business liability insurance, but it's not okay for health insurance. It's not okay, in my view, that those of us who are unlucky enough to have a health problem be the ones who are least able to obtain health insurance. We're all in this together. We ought to be sharing the load together. And a community-rated premium forces us to do that. So the premium is the same for all comers. So if you're in the HIPIC, each plan has a premium. That premium is what is paid by everyone who chooses that plan within the HIPIC. And of course, the HIPIC negotiates that with the providers, as I said, in order to bring it down as low as possible. I meant to mention, I will now, that these managed care plans are prepaid capitated plans. That's what we're going to see. So you pay the premium, and for that premium, the provider is obligated to deliver to you all of the health care that you need. There's no balance billing, as there is in a common insured plan. This gives the provider a strong incentive to be very efficient in the way it delivers health care and to manage that care carefully, because the more they deliver, the less they make. So it changes the incentive. The incentive now is the more the provider delivers, the more the provider makes. So that is where I think we're going. And I think it's pretty good. And that If we stay the course, we'll have universal access to an adequate level of health care at a reasonable cost. And it will probably start happening, I would guess, I would hope, in about 1997. So let me just conclude by ticking off sort of the cost containment pieces of what I've just described, because that's what a lot of us are very concerned about. Pocketbook protection, that's provided through the individual system. The fact that we're paying taxes to provide health care for ourselves and the other Oregonians, and we know what that is costing us. We're going to care when those taxes start going up. The purchasing power of the health purchasing corporations, that's going to bring things down. Competing, really, genuinely competing health care plans, such a thing we haven't really seen to date. For some reason, normal supply and demand and competition doesn't seem to work in the healthcare field. We think it will under this system that I've just described. Prepaid managed care, which changes the incentive so that care is efficiently delivered, and all of this done without any government regulation of prices, which is something I hope we can avoid. So that's the plan, and I would be very interested in your questions in the time that we have left. Thank you.
Thank you both. It is time now for questions from club members. Please use the microphone, which is available directly in front of me here, and keep your questions brief, focusing on getting to a question mark as quickly as possible. Please indicate when you ask your questions which one or both of the speakers that you're directing them to. Our first question today comes from Vivian Solomon, member of the board.
Thank you, Don. This is a question for both speakers. The Oregon Health Plan legislation called for public meetings about Oregonians' values. Those meetings were conducted by Oregon Health Decisions. My question to you is, how vital were citizens' values in formulating and implementing the plan, and also what plans are there for continued citizen input?
I appreciate the question. Oregon Health Decisions may be why Oregon was able to get out in front on this issue. Oregon Health Decisions began probably 10 years ago now by Dr. Ralph Crawshaw, who is here, by the way, and I will give credit where credit is due. About 10 years ago, began to talk to Oregonians throughout the state about the tough health care choices that lay ahead, knowing that we couldn't do it all, knowing we had to make health decisions. This got the state, the body politic of the state, ready to think about these things when we had to address the issue. And so when the public input was sought and provided through Oregon Health, with Oregon Health Decisions' help, the people were ready to give it in a conscientious and thoughtful way. And it really, I think, had the effect of allowing us to do what we did in 1989, because these people, of course, had influence upon their legislators, their representatives, and that was reflected in the action that we took. I can't answer precisely what is going on right now regarding that. Ralph perhaps can, and perhaps it'd be appropriate to speak to that for a second if you think that's okay, Don.
I'd like to speak a little bit to it because in any planning on implementation, and Bob addressed the Oregon Health Decisions work on planning for the Medicaid prioritization and talking about what people value in the healthcare delivery systems. As we move towards implementation, I can tell you on behalf of the governor that the Oregon Health Council, who is right now charged with the responsibility to look at questions of access, questions of financing of our healthcare system, questions of healthcare delivery. They are deliberating those questions right now. One of the first things that they talked about was how do we get public input? they're going to go out even before they really start to begin to grapple with the hard issues, and they're going to hold public meetings around the state to talk to citizens and to get that input, because we realized from an early time that citizen input to the plan is vital to the success of the plan.
Sandy Marin, co-chair of Human Services Standing Committee. Senator Shoemaker, I have a question for you. You talked about the funding for what you call the individual mandate portion, but I'm interested also in what you think should be the funding for the Oregon Health Plan, the Medicaid section. Representative Walden favors funding this plan entirely from the general fund and lottery fund dollars, whereas former Senator John Kitzhaber believes that we need new revenue to get the health plan started. Do you favor new revenue, and if so, what kind of tax would you support?
Thank you. In the long term, I favor the health plan being paid, the Medicaid portion being paid from general fund revenues, competing with everything else. That was the original concept, and it was a very important reason why we did what we did. So I do think we have to stay with that. However, we didn't have Measure 5 in our laps in 1989, and we really cannot afford to dig to any substantial degree into general funds this year to fund the additional costs of the plan. We are still funding a substantial Medicaid program within general fund. Yet we have to do it. We have to fund the plan. We've got a 5-year pilot program. I think it's very important that the state step up and do it. So I think we must look elsewhere for the startup of the plan, even though it's not consistent with the original idea. What do I favor? I favor a mix of tobacco taxes and a provider tax, and I could spend some time describing why I think the provider tax is fair and is a benefit to the providers. It may well not be politically possible to achieve that. I suspect that it is not. If not, I do not favor using the lottery. The lottery is committed to other important projects, and I don't think we should divert to that, nor do I think it's the kind of stable source of funding that we ought to look for if we need to keep this bridge financing going for several years. So I think we're left with a tobacco tax and probably a small amount of general fund as the most probable way that this will be funded.
Ted Kay, City Club member. Bob, you said that those unlucky enough among us to be in poor health shouldn't pay more, but what about those whose behavior increases their likely cost to the system? Take, for example, smoking. On average, smokers have significantly higher health costs than non-smokers. Community rating doesn't seem to place the cost of smoking where it belongs, on the smokers. I'm just using that as an example. There are other voluntary ways where people can reduce their medical costs that this system doesn't seem to incent them to do so.
That's a very fair comment. It's one that is occasionally made against community rating. I think the answer is that you can't probably do them both effectively. I think community rating is fairer in the long run. Education is probably the most important way to get at poor habits rather than hitting people over the head with it by forcing them to pay health premiums which they probably can't afford. An emphasis on preventive care should also help. And to the extent that people are still obtaining health care through their employers with community-rated premiums perhaps attaching to that employer's pool, the employer has a strong incentive to keep a healthy workforce. So there still are ways to get at that. I think to give up community rating in order to accomplish what you suggest is too high a price to pay.
If I might, Bob, just because I don't want us to look like we agree on everything that's asked today, because we actually do agree on many, many things. I agree with Bob on community rating concept, but I also think, and I agree with the questioner, that we need to find ways to incentivize good health behaviors. And I think that even if you have a specific community rating, I think there can be incentives built in that people can get cash back in their pockets if they know that they behave in ways that don't contribute to detrimental health. So I've been looking at it. I sit on the State Employee Benefits Board, one of the two benefit boards that buys health insurance for state employees, and we've been wrestling with this issue for some time. And we have arguments because people say very clearly that they don't want the health plan to discriminate against them because they smoke. Well, what I want to and have been successful in doing is to say we're going to pay half the costs of a program that helps you kick the habit. But we're going to give you only a certain period of time to do that, and after that, you're going to have to pay more for your health care. And that's the way it's going to be.
Mike Katz, a member of the City Club. Are hot potatoes in order? I don't
Oh, they wouldn't be the first one, Mike.
I have a couple. I think if I understood Bob, you said that all taxpayers would be paying some sort of a surtax or health tax. And my first hot potato has to do with those who are taxpayers but don't particularly care for health coverage. For example, Christian Scientists, or with respect to some medical procedures, Jehovah's Witnesses. And my second hot potato is, would the health care plans provide for abortion services? Or if the answer isn't yet known, how will it be decided?
Okay. I'm not sure I can answer the second of those because the plan hasn't been developed yet, but I expect that it would to provide for abortion services. There would be an opportunity for providers who have conscientious objections to abortions to opt out of providing those. That's in the plan that exists today. Beyond that, I think you'd find that it would be provided. Regarding those usually religious groups that don't wish health services and have a belief against it, I haven't really thought about that. Perhaps a credit respecting that would be fair. There aren't a lot of those people in comparison to the whole population. I don't think it would disrupt the total plan to do something like that. But I frankly, I don't know, Mike. I haven't really thought my way through that one yet. Roger, do you have thoughts on that?
Well, I think your response is similar to what mine would be. I think that there has to be some exemptions in the plan while we want everybody in underneath so we can get rid of the cost shifting that's gone on for many, many years. I think what you're going to have a basic question of freedom of religion, and I would rather deal with that up front in some kind of legislation before, rather than argue it in the courts.
Ann Madden, City Club member. This question is for Senator Shoemaker. It has to do with the vision of this interesting plan of yours. I can see these 5 or 6 HIPPICs, and then I can see these various managed care providers. In Portland, it would be like Legacy or the Sisters or whatever. But what would happen to insurance companies? Am I missing something? Would they go away?
Largely, yes.
Hasn't anybody
Yeah,
worried
and
about that?
let me just enlarge on that a little bit. A health maintenance organization or managed care organization assumes the risk. They take the risk of care. They may reinsure that risk. That is, they may insure their own exposure to risk, so there is still room for some insurance. But insurance companies, as between the consumer and the provider, probably will fade away, yes. Yeah, it is.
I might also comment. This is, although I want to give Senator Shoemaker the credit that's due him, there are some people in the White House who are also working on this managed competition system. And so I've also been following with great interest what's going on. And that is the question that I first asked, is what happens to the insurance companies? And I think what we'll see is either they will link up with your provider community and they will be partners in providing services, medical services, and I think others will naturally sort of go towards the health purchasing side. I think those insurers that are closely linked, again, with providers who have facilities and don't just buy services will end up on the provider side, and I think the other insurers, health maintenance organizations which buy services from providers now may end up just buying services and be on the consumer side. So there's going to be a role for them.
Don Sterling, a member. I'll address this to either who wants to take it on, Mr. Auerbach's remarks lead right into it. How do these plans, the Oregon plans, fit into the two existing two federal medical insurance plans, the Medicare, which now exists, and the Clinton administration health plan, which may exist?
Thanks, Don. Right now, what we're hearing from the White House, and I'm lucky enough to be in on weekly or bi-weekly conference calls with the White House as they move towards announcing their health care reform plan. Very clear that Medicare will not be folded in immediately into the plan. I think it's just, it takes too much political will, which probably is not available for that to happen. With Medicaid, I think what we are going to see is on a statewide basis that states will have a lot more flexibility than we originally thought in terms of delivery of health care services. And I think what is envisioned is that states will be allowed and actually will be given incentives to move their Medicaid population into into the same insurance system. I think we'll be prepared to do that, and I think our state will be able to benefit from the incentives that the federal government is talking about because we are so well progressed in our thinking on how we want to deliver health care in our state.
And the Clinton plan, for the general population, what about it?
Well, there isn't one yet. Roger may want to comment on this, but the signals I'm getting are that it might not be totally unlike what we're thinking about. Although the individual mandate, I don't know that yet is under serious consideration in Washington. But the use of HIPAAs as a pooling organization certainly is. The whole concept of managed competition seems fairly central to their thinking. So I think what we do will probably turn out to not be inconsistent with what the federal government eventually does. And in the meantime, as I think Roger said, states are being encouraged to try new things.
And Bernie Reed, City Club member. Senator, could you give us an estimate as to how much this monthly tax would be for an individual and or a family?
I don't think I can with very much confidence. Perhaps, I mean, I really can't. But the total costs to the public should in the long run be less than they now are.
So probably in the range of $300 to $500 a month?
No, I wouldn't think it would be that much. I would think it might be more in the range of $100 to $150 a month. Which would be substantially less than premiums. I'm not sure where the extra money comes from. Well, we've been developing some public plans. The Medicaid plan that is about to be funded, I think comes in at a capitated rate of about $130 or $140 a month for each person covered under that plan. And this shouldn't be too different from that.
I guess my question has to do maybe more with the family. If you have 3 or 4 people in a family, you're looking at $600 to $800 a month tax.
It isn't a direct relation. You don't just multiply it by the number of people because the risk does change with the size of the family and the age of the family. So I would expect that the family premium would be 2 or 3 times that.
Thank you.
Joseph Lidrich, City Club member. Implied in the program is that, it's going to be an improvement. To do that, I think you have to have some way of measurement. Typically for a medical system, one way of measurement is infant mortality, longevity. If you divide by dollars, you get a coefficient, which you can say is efficiency. You can measure your plan. Has anybody thought of doing that as to how it's going as you move along in it?
Well, we would certainly develop ways to measure the plans as they develop. At this point, we don't have it in place. We don't even have the Medicaid plan actually in place. But we certainly will be developing ways of measuring effectiveness. A lot of work is going on such things as outcomes research to sort of see what works and what doesn't. I think we'll be developing that as we go along here. As the public becomes more and more directly involved in the cost of health care, I think you can see more and more public insistence on just exactly the kind of measurements that you're talking about.
In addition, the state of Oregon has adopted benchmarks in a lot of different areas, goals that the state should be seeking and reaching towards, and really trying to judge how well we're doing. And we have a lot of benchmarks in healthcare. Infant mortality is one of those. Teenage pregnancy, reduction in teenage pregnancy is one of those. Cost of healthcare, the fact that people should have insured access to healthcare are all benchmark goals for the state of Oregon. So we've been working on these and looking at those targets. I agree with Bob that we need to have quality standards as we move into the next century for healthcare plans and a way to judge. I think one of the things that Bob's colleague may even do this afternoon or tomorrow in terms of the health plan is talk about consumer data, putting in the hands of consumers some basic information about the price of healthcare, what things cost by different providers, and some quality measures so that consumers can judge where in fact they should spend their healthcare dollars.
Let me just make one other comment. As we move into a prepaid system, which is clearly where we're going, quality measurement becomes, and quality control becomes even more important. The present American healthcare system, in terms of quality, is without doubt the best in the world. It's also the most expensive in the world. As we make it less expensive and change the incentives, quality is going to have to be looked at very carefully. It is probably going to be the major problem once we've got a change to the new system under our belt.
Ted Falk, City Club member. I have two questions about employers that choose to continue to furnish health insurance. For both speakers, we read in the Oregonian earlier this week that there appears to be some ambiguity about how employer participation would be measured. And so my question is, how would you decide if an employer has a health plan, has satisfied the employer mandate, or has satisfied this new plan that Senator Shoemaker has described? And then I also have a question specifically for Senator Shoemaker. Why do you consider it undesirable for employers under your plan to continue to furnish group health insurance?
Okay, Ted, let me take the first one since you asked Bob specifically the second one. Bob, why don't you go on that? I had a good one there, Ted. But the measurement, I'm back on.
Go ahead. You do it.
Because this is an easy one, right, Bob? I was going to try to give him the hard part. The measurement for whether an employer complies or not under an employer mandate, we've been looking and talking about that. We're trying to get to the system that requires the state to do the least regulation possible. That, in fact, we expect that employers will comply. We have a workers' compensation system model that we are thinking about very strongly of following, which means that we will find out about, unfortunately, about employers who aren't complying when someone comes in for care and does not have that card, does not have some insurance. That is the way we'll find out. We want to try to make this the least regulatory system possible.
Okay. I anticipate that we will require that every employer provide the basic Oregon plan. In other words, wherever you get your plan, at least has to be the Oregon basic plan. And it has to be a certified plan. That is, the Department of Insurance and Finance has signed off on it as financially responsible and sufficient quality indicators. And then to assure that the employer is in fact providing it, I think, is a mechanical thing, so I don't think that'll be a significant problem. Why is it desirable to discourage employer-provided plans? One reason is that if everybody were in the HIPAAs, you'd have the greatest possible negotiating clout. The fewer purchasing organizations you have negotiating with providers, the more clout they've got in bringing the price down. With a great number of purchasers, the providers have a lot easier time of it out in the marketplace. Another reason is that as you pool everybody, both high risk and low risk, into a single pool, you tend to bring the community rate that we all pay down. I think one of the problems with having continuing employer pools is that the low-risk people tend to be those who are employed, particularly in the substantial companies. So you've got a sort of a cherry-picking thing already built into your system where your people with the least amount of risk are in their own separate plans and are able to get lower premiums for themselves. I'm not sure that's desirable from a society perspective.
We have time for one more question, please.
Liza Miller, City Club member, and either one of you can respond to this question. Will employers who choose not to continue to cover their employees on their own be required to pay the individual base rate for the employee alone or for the entire family? And if they do not pay the employee for the entire family, the employee then has to pay for their own family out of their own revenue?
Under the individual mandate, the employer would not be required to provide any health care at all, just as they are not now. So the question has to be then, if we go forward with the employer mandate, which we very well might do, and that is a question that hasn't been answered yet. That's one of the ones that needs to be worked on during the interim, and one of the tasks that will be assigned to an interim task force by this bill that I mentioned would be that, to develop, do you have to cover the whole family? To what level should the family contribute as compared to the employee himself? What kind of co-payments and deductibles? Those issues are not yet resolved.
Senator Roger, I want to thank you both very much for a superb basic education course in what obviously is going to take a lot more study, if not a graduate degree, by the time we reach it. Thank you very much. We're adjourned.